All right, good afternoon. I'm delighted to get us started off, and now I don't have to say my name, which is even better. Um, so I will be talking about sort of econometric methods or the role of health economics and how we can measure and identify racial and ethnic inequities in patient experience of care in the Medicaid managed care program. And so just to orient everyone, enrollees from racial and ethnically minoritized groups have historically reported significantly worse experiences of care in the form of access to care as well as satisfaction with care compared to their non-Hispanic white peers. And so this has resulted in these inequities in patient experience of care, which I want to note are the product of systemic inequality and racism, as well as these interwoven patient, provider, and plan level factors. And I really intentionally use the term inequities, which refer to sort of unfair and avoidable differences by social positioning and identity. So one role of sort of econometric methods and how we can apply this lens to this work is how we can sort of decompose variation in terms of within versus between plan effects, because this can inform the interventions that we use. So within plan effects might indicate that on average, a person who is from a racially or ethnically minoritized group would experience worse care or have worse access to care than non-Hispanic white people within the same plan. Whereas a between plan effect might indicate that there's sort of disproportionate enrollment of people of color in lower performing plans. And so as you can imagine, this can inform a different type of intervention. And so this study, which was published in the inaugural Racism and Health issue of Health Affairs, looked at 4 different outcomes, but I'm going to focus on one in the interest of time, which is timely access to specialty care. And so just to orient you to this graph, the purple sort of section indicates the within plan effect, and that turquoise bar would indicate the between plan effect. So compared to non-Hispanic white enrollees in Medicaid managed care, those from racially or ethnically minoritized groups, on average, particularly from Black, Hispanic, or Latino, and Asian American, Native Hawaiian, Pacific Islanders, reported significantly worse timely access to specialty care, and this was really driven by this within plan disparity. And so, some key takeaways here. Compared to white enrollees, those who were from racially or ethnically minoritized groups and enrolled in these Medicaid managed care plans reported significantly worse experiences of care on all 4 metrics that we looked at, and the differences were almost universally attributable to these within plan effects. I'm not going to go into that third point in the interest of time, but what I want to sort of focus on is, this sort of indicates the role of econometric methods in understanding, identifying, and measuring these inequities, which I hope that a lot of us as researchers want to use to inform policy and interventions. So, I will highlight a few different interventions that are currently in place at the plan level, so these Medicaid managed care plans, that are somewhat informed by these findings and these within plan effects. Some plans are adopting health equity performance measures. Some are expanding their provider networks to be more culturally and linguistically inclusive, and some are trying to use this data to more directly engage with enrollees from minoritized groups. And I think this is very promising and one important way in which we can apply this health economics lens to health inequities. I will note, however, which I hope sort of ties a lot of this work together, is that I hope that these initiatives are ultimately cross-sectoral, because it is important to dismantle these mutually reinforcing systems that perpetuate this differential access to care by race and ethnicity. With that, I thank you for your time, and I won't be here for the TAP part, but please feel free to reach out via email.